Guys, welcome back to the channel. Today we discussing the CRASH 3 trial. Effect of tranexamic acid on death, disability, vascular occlusive events and other morbidities in patient with acute traumatic brain injury. Last slide or last जो PPT I have uploaded, they only choose the patient only for the vascular hemorrhage patient. Here is the patient we choose the acute traumatic brain injury.
Disclaimer: the content and information on this video is for education purpose only and is not intended to be recommendation of any kind of sum whatever. Under any circumstances, the author accepts no liable for any indirect, incidental, consequential, exemplary damages arises. This video may contain copyright material, the use of which may not have been specifically authorized by copyright owner. This video is available in an effort to advance understanding of education and content.
In a patient with a traumatic brain injury, does the administration of tranexamic acid under 3 hours from the injury compared with a placebo reduce the head injury associated in hospital mortality within a 28 days? Clinical question for this study. Background: there are limited trials have been looked at the use of tranexamic used in traumatic brain injury, an extremely common cause of mortality and morbidity. TICH2 used for the tranexamic acid in spontaneous intracranial hemorrhage but not the traumatic bleeds. Two small trials set in India, Colombia and Thailand found no statistical improvement in mortality in isolation. Meta-analysis did not show reduction in mortality. There has been found a recent trial in USA, RAW, Trenexa, although this is not yet to fully published. Design for this study: randomized placebo control trial, random allocation through the removal of the lowest number treatment pack available. Pack labels on Trenexa and placebo identical and content checked to ensure coding and content correct with random testing. Pack prepared with randomization codes from the independent statistician. Participation and study staff blinded. Initial power calculation: approximately requirement of 10,000 patients to have 90% of power. Sample size increased to 13,000 as a primary outcome changed to in hospital within 28 days and recruitment limited less than 3 hours of injury due to emergence of data surrounding time frame and effectiveness of the tranexamic acid. Pre-specified subgroup included head injury, severity type to tranexamic and age. Multiple variable model used to control age, systolic BP, traumatic brain injury severity. Primary outcome of head injury associated death was assessed by the responsible clinician for adverse events to record pulmonary embolism, DVT, then radiographic postmortem readings are required. Outcome data collected by 28 discharged from the randomization hospital on death, which were found to first. 19% of hospital records monitored on the site are remotely, including 67 of these who died from the head injury. Intention to treat diagnosis: 175 hospitals in 29 countries, July 2012 to January 2019. Population for this inclusion criteria: adult with a traumatic brain injury within 3 hours of injury, came from within 8 hours of injury in September 2016. GCS less than 12, intracranial bleeding at CT, no major extra bleeding, external bleeding. The treating clinician had to substantially uncertain is the appropriateness of tranexamic as a treatment. Inclusion criteria now listed: 12,737 patients randomized, 406 tranexamic, which is 464 randomized in less than 3 hours, 4,613 out of 4,649 analyzed, 13 withdrawn consent, 7 had data available, 29 lost of follow-up, 6,333 1% to placebo, which is 4,553 were randomization less than 3 hours, 19 patient withdrawn consent, data available, 20 patient lost of follow-up. Baseline characters: age, sex, time, sign since injury, systolic BP, GCS, papillary reaction well matched. 27% in tranexamic group and 28 patients in placebo group had a GCS 13 to 15, therefore must have been had positive CT scan. Intervention: Tranexamic acid 1 gram over the 10 minutes followed by IV infusion 1 gram over the 8 hours. Control placebo 0.9% normal saline. Use for the otherwise identical. Management common to both groups. No information published regarding to ongoing management. Outcome. Primary outcome 20 day 28 day in hospital. Head injury associated mortality in patient assigned within 3 hours of injury. No significant difference. Tranexamic group 855 versus 892. Relative risk 0.94%. Pre-specified group analysis for primary outcome. 20 day 8 in hospital traumatic brain injury with mortality in Tranexamic group 485 versus 525. Patient with mid to moderate traumatic injury GCS 9 to 15. 28 day in hospital traumatic brain associated mortality in Tranexamic group 166 versus 207. You can read this and you can screenshot for the more information. Strain. This is extremely large multi-center trial across the range of countries. Increase the external validity, good internal validity, extremely well-balanced baseline characteristics, minimize the selection bias, randomization and protocol for blinding, minimize the detection of bias, smaller number of protocol violation, pragmatic design to allow timely access the intervention, principally specified subgroup GCS and popular reaction as easily accessible in the pre-hospital settings. Do not record the CT scan. This is important given to demonstrate the ease by tranexamic can be administered in out of hospital setting in other large trials. Although saying this large portion had a GCS more than 12, therefore must have a positive CT scan prior to administration. Important that study also consider patient focus outcome, patient-derived disability migration to mortality. This is the weaknesses. The primary outcome 28 day in hospital head injury associated mortality could be certain the cohorts of patients. There will be arguably corresponding rates by given the 28 days that have been occurred as a direct result of the traumatic brain injury. Some death will be due to the withdrawal of medical care. Small subset of patients may have been discharged into another care setting may not be survived at 228 days. However, discharge alive from the Dynamite hospital be recorded as survival. This is a weaknesses for this study. You can read this from the slide. The tranexamic safe in traumatic brain injury that treatment within the 3 hours reduce the head injury associated death. The study suggests that this is an enormous and well-designed pragmatic trial design to answer a question with a limited evidence base. Traumatic brain injury still has a 28 day in hospital mortality, nearly 20% in placebo group. This is similar to the MRC crash trial which started recruitment in 1990. Tranexamic administration in traumatic brain injury appears safe. However, the conventional statistics does not appear to reduce the hospital traumatic brain injury death at 28 days when administered less than 3 hours. Hopefully, longer term data will be published due to course. Interesting debate on continue to occur as to whether subgroup analysis can be used to apply changes in clinical practice. If it is mild to moderate traumatic brain injury, would be the advocating for the them to receive tranexamic given it is low risk to harm. Thank you guys.